السلام عليكم ورحمة الله وبركاته. أهلا بكم يا شباب سنة رابعة في ظل الظروف الاستثنائية، يا رب تكون إن شاء الله عاقبتها خير. معاكم دكتور محمد فواز، أستاذ مساعد الأنف والأذن والحنجرة بجامعة بني سويف. الموضوع اللي هنتكلم عنه النهاردة هو النيزوفارنجيال كارسينوما، وده تحت العنوان الكبير اللي اسمه Diseases of the Nasopharynx. أوكي. طبعا disease of the Nasopharynx تشمل حاجات كتير، اللي يهمنا منها طبعا نيزوفارنجيال كارسينوما، وده اللي هنتكلم عنه النهارده. وفي المحاضره الثانيه هيبقى النيزوفارنجيال انجيوفايبروما. مع بعضينا كده هنحفظ سكيما عشان يخلينا نفتكر المعلومات كويس ونفهمها كويس، لان لازم نحفظ ونفتكر ونبقى فاهمين طبعا والفهم. طيب، نيزوفارنجيال كارسينوما، علشان اتكلم عن نيزوفارنجيال كارسينوما في فيكسد ايتمز I want to speak about. اول حاجه الانسيدنس، الاناتومي، predisposing factors, pathology. والpathology includes 6 items: size, gross, microscopic picture, spread, staging, and differential diagnosis. بعد كده clinical presentations means clinical picture. Then investigations of any tumor includes one of 3: either laboratory investigation, radiological investigations, or biopsy. The last point is the treatment. I want to treat this patient, and treatment is 2 types: either curative treatment in early stages of the tumor. My aim is to cure the patient completely. Number 2 is palliative treatment, and I want to palliate the patient. I want to improve the quality of life of patient until he passes away. This occurs in advanced stages of the tumor. Treatment also include treatment of the primary tumor and the treatment of the draining lymph node. So let's begin with incidence. Nasopharyngeal carcinoma is the most common malignant tumor of the nasopharynx. What are the other types of malignancies that occur in the nasopharynx? They include salivary gland tumors, minor salivary gland tumors, lymphoma, rhabdomyosarcoma, and this will be mentioned in differential diagnosis later on. More common in Chinese. Why? We will know nasopharynx. This is the area of the nasopharynx. Roof of the nasopharynx is formed by the skull base. This is the sphenoid sinus. This is the pituitary gland. The posterior wall is formed by the first and second cervical vertebrae. Anterior boundary is the back of the nose, and the lower boundary is the soft palate, which separates the nasopharynx from the oropharynx. So the next point, the predisposing factors. Number 1, Epstein-Barr virus is a viral infection that makes the patient more predisposed to develop nasopharyngeal carcinoma. Epstein-Barr virus also causes infectious mononucleosis. This is one of the differential diagnoses of tonsillitis, is infectious mononucleosis. And by the way, the symptoms of infectious mononucleosis is very similar to coronavirus infection. In these cases, we found the patient will complain of bony aches, mild sore throat, tenderness in muscles and joints, and very minimal finding in the oropharynx. If we have a look at the oropharynx of the patient, we will find minor congestion, not the severe congestion, and pass as in case of acute tonsillitis. So, Epstein-Barr virus infection is the major predisposing factor of nasopharyngeal carcinoma. In otolaryngology, it causes also infectious mononucleosis, and it causes also bulbar paralysis or cranial nerve paralysis, which may result in vocal cord paralysis. These are the viral infections in otolaryngology caused by Epstein-Barr virus infection. After that, genetic. Chinese are genetically susceptible to nasopharyngeal carcinoma. We don't know why. Maybe the Chinese fault, we don't know up till now. Others include nitrosamines and formaldehyde. Pathology. Regarding the pathology, as we mentioned before, there are 6 items I have to comment on to do complete pathological report about any tumor: size, gross, microscopic, spread, staging, and differential diagnosis. These points are fixed pathology points in the pathology of nasopharyngeal carcinoma, pathology of cancer larynx. I will remember these 6 points. pathology of glomus tumor, pathology of acoustic neuroma, all these tumors, the same scheme of pathology I will follow in all these tumors. Site, fossa of earthen molar is the most common site in nasopharyngeal carcinoma, and this is the site of fossa of earthen molar. This is the Eustachian tube opening. This picture is by endoscopy in the left nasal cavity. This is the Eustachian tube opening. Eustachian tube opening is guarded superiorly and posteriorly by a ridge of cartilage. Behind this ridge of cartilage is the fossa of earthen molar. This is the most common site for nasopharyngeal carcinoma to originate. However, nasopharyngeal carcinoma can originate from any site in the nasopharynx. Gross picture, as we know, any tumor that occurs in a capacious organ, either surface epithelium or capacious organ like the intestine, like the stomach, like the larynx, like the oral cavity, like the nasopharynx, will take one of three forms of growth, either ulcerative pattern, or exophytic or cauliflower pattern, or submucous infiltration. This means that the tumor is spread submucosally with intact superlying mucosa. Microscopic picture of nasopharyngeal carcinoma. This is squamous cell carcinoma in 85% of cases. WHO classification for nasopharyngeal carcinoma, squamous cell carcinoma, according to the degree of differentiation. Type 1 is a well-differentiated tumor, and this represents 25% of nasopharyngeal carcinoma. Type 2 is a non-keratinizing carcinoma, and this represents 15% of nasopharyngeal carcinoma. And type 3, which is the undifferentiated carcinoma. So, why we classify squamous cell carcinoma according to the degree of differentiation? Because the prognosis is better with undifferentiated or poorly differentiated tumor. Because undifferentiated tumor is a very aggressive tumor, and the tumor have no time to form new cells similar to mother cells. So the tumor growth is very rapid. However, this unformed cells, this not well formed cells are more responsive to radiotherapy than well-differentiated tumor. So well-differentiated squamous cell carcinoma is less responsive than undifferentiated or poorly differentiated squamous cell carcinoma. Likely, undifferentiated carcinoma represents 6% of nasopharyngeal carcinoma. This increases the rate of response to. Regarding the spread of any tumor, we don't have to revise the spread. We have to invent the spread every time, because if I know the anatomy where the tumor originates, I can expect where the tumor can go. So, from this picture, anterior spread to the anterior nasal cavity and may fill the nasal cavity, and may spread to the orbit. Superiorly, it may pass through the skull base to the brain. It may get attached to the cervical vertebrae. It may get downwards to the oropharynx. So I can expect the spread of the tumor every time. Staging of nasopharyngeal carcinoma. ده طبعا مش عليكم في سنة رابعة، الخطوة دي نعديها. Differential diagnosis of nasopharyngeal carcinoma. 2 points. I have to differentiate nasopharyngeal carcinoma from other nasopharyngeal malignancies زي ما قلنا قبل كده lymphoma, salivary gland tumors, or rhabdomyosarcoma. Especially في الأطفال, rhabdomyosarcoma occurs more commonly in children. Salivary gland tumors, what means by salivary gland tumors? It means the minor salivary gland tumors. We have major salivary gland tumors, which are the parotid, submandibular, and sublingual gland tumor, sublingual glands, and there is minor salivary gland distributed in the all upper aerodigestive tract, and they may give origin to tumors. Number 2, in differential diagnosis, I have to differentiate nasopharyngeal carcinoma from other nasopharyngeal swellings like adenoids. Adenoids is the most common benign swelling of the nasopharynx, and the nasopharyngeal cyst. This is a benign cyst, congenital cyst, which is present in the nasopharynx, and from the picture I will show you later on, you will know how to differentiate between tumor and benign tissue by the naked eye. Clinical presentations. To simplify clinical picture, we have 4 major groups of symptoms in nasopharyngeal carcinoma. Oral symptoms. Oral means symptoms related to the ear. Number 2, nasal symptoms. Number 3, neck mass. Number 4, neurological manifestations. These are the 4 major groups of clinical presentations related to nasopharyngeal carcinoma to simplify الشرح. الأورال symptoms طبعا unilateral secretory otitis media due to second tube obstruction in the same side of the tumor. This will result in secretory otitis media. As you see in this picture, there is a fluid level, the fluid level, and there is signs of retracted drum as foreshortened hand of Milius, prominent lateral process, and so on. Nasal symptoms in the form of unilateral or bilateral nasal obstruction. Any nasal obstruction will cause retention of secretions, and these secretions will come anteriorly from the nose of the patient, so there will be unilateral or bilateral nasal discharge. As we speak about tumor, this may be epistaxis, and as a result of nasal obstruction, the patient will be mouth breather and there will be snoring. This is a fixed items with any tumor, with any fibroma, with nasopharyngeal carcinoma, with adenoid, with any nasopharyngeal neck mass. The patient may present with neck mass as a result of lymphatic spread to the cervical lymph nodes. And lymph node enlargement as a result of nasopharyngeal carcinoma is characterized by being painless. Lymph node enlargement due to carcinoma or due to lymphoma will be painless. In comparison to inflammatory lymph nodes, as with tonsillitis, pharyngitis, and so on, it will be tender lymph nodes. So when I find the painless lymph node, I have to suspect malignancy in any. Okay, this is the neck mass. Neurological manifestations. Because the nasopharynx have a roof, the roof of the nasopharynx is formed by the skull base, and the skull base is the site of passage of nerves and the vessels. So cranial nerve pulses can occur as a result of nasopharyngeal carcinoma. Neurological manifestations include xerophthalmia. Xerophthalmia means decreased lacrimal secretion. What is the relation between the lacrimal gland and the nasopharynx? We know that the roof of the nasopharynx is formed by the skull base. The sphenoid sinus is present in the roof of the nasopharynx. The floor in the floor of sphenoid sinus there is a canal, bony canal called pterygoid canal or median nerve, which includes the greater superficial petrosal nerve and the deep petrosal nerve. Greater superficial petrosal nerve is the nerve supply, which gives the parasympathetic supply to the lacrimal gland. So one of the earliest signs of nasopharyngeal carcinoma is lost lacrimal secretion on the affected side. Number 2, facial pain. It means the pain in the face due to affection of the trigeminal ganglion or one of the branches of the trigeminal nerve. Diplopia due to affection of the cranial nerve number 6. What is the relation between cranial nerve number 6 and nasopharyngeal carcinoma? Cranial nerve number 6, or the abducent nerve, is the thinnest trunk in all cranial nerves. It has the thinnest trunk, and it passes on a sharp edge, which is the petrous apex. So any minimal increased intracranial tension will cause cranial nerve 6 palsy. Ophthalmoplegia means the paralysis of cranial nerves number 3, 4, and 6 due to invasion of the tumor to the superior orbital fissure, or so the superior orbital fissure is a lateral and anterior relation to the sphenoid, to the nasopharynx. Horner syndrome. This is paralysis of the sympathetic cervical sympathetic chain due to lateral extension of nasopharyngeal tumor through the superior constrictor muscle, then to the parapharyngeal space where the carotid sheath is present. Trotter's triad. As we like triads in Egypt, there is unilateral facial pain, unilateral palatal immobility, and unilateral conductive hearing loss. If I found this triad, it is pathognomonic of nasopharyngeal carcinoma. However, we usually didn't find this triad in every case of nasopharyngeal carcinoma. Okay. This is a picture of endoscopic view from the right nasal cavity to the nasopharynx. How did I know that this is the right nasal cavity? This is the second tube. This is the nasal septum. So if the nasal septum is on my right side, so this is the right nasal cavity, and the vice versa. So this is the right second tube opening. This is the thorax tuberous, elevation above and behind. This is tumor from the other side and coming to the right side. We can notice the hemorrhage and the increased vascularity of the tumor and the ulceration of the surface mucosa overlying the tumor. This is a very interesting picture because in this picture I can differentiate between malignant and benign tumor by the naked eye. This is an endoscopic view of the right nasal cavity passing to the nasopharynx. This IT is the inferior turbinate. S is the nasal septum. The nasal septum is on my left side, so I am in the left nasal cavity. And this is the tumor with the hypervascularity and the cauliflower pattern. And the downwards lies the adenoid. This is the adenoid, a benign swelling in the nasopharynx. However, there is no surface ulceration. And it has the same blood supply like the nasopharynx, like the floor of the nose, like the inferior turbinate. It has the same homogeneous blood supply. However, the tumor has increased the blood supply. So by naked eye, I can confirm that it's a malignant tumor. It's a tumor, benign or malignant. After I take a biopsy and examine under the microscope, I can determine if there is malignant criteria. It is a malignant tumor. If there is a benign criteria, it's a benign tumor. However, by the naked eye, I can confirm that it's a tumor. Okay, this is a nasopharyngeal cyst. It's a benign swelling also. It has the same homogeneous blood supply like surrounding structures and covered by intact mucosa, so it's a benign. This is a nasopharyngeal lymphoma. Also, there is hemorrhage and ulceration above the mass, which occludes completely the quena. It occludes the left nasal cavity, the right nasal cavity, and you can observe also retained secretions in front of it. Okay. Radiological evaluation, the most important tool in diagnosis of nasopharyngeal carcinoma is the CT, because the nasopharynx is surrounded mostly by bone, and any bone erosion will be manifest or can be seen more with CT than MRI. Do MRI in case of soft tissue invasion, in case of tumor extension intracranial, tumor extension to the orbit, tumor extension to the parapharyngeal space. MRI will be beneficial at this stage. In this picture, this is an axial CT. CT may be axial. This means I take cut from the hairs to the chin downwards, and in this picture I can see the eye globe, right and left eye globe. This is the nasal septum. Okay, this is the ethmoid ear cells. This black color is the color of ear, so it is the normal ethmoid ear cells. And this is the area of the nasopharynx. This is the area of the optic nerve. This is the area of the optic nerve. This is the medial pterygoid muscle. This is the lateral pterygoid muscle. So in this area above, if I cut a CT cut at a superior level, I will find the superior orbital fissure. This explains why ophthalmoplegia occurs with nasopharyngeal tumors. And this is the petrous apex hair. This is the petrous apex hair. So this explains why the trigeminal ganglion and the fifth cranial nerve can be affected in case of nasopharyngeal carcinoma. And this is the tumor in this area. This is a soft tissue mass filling the nasopharynx in this area. This is an example CT. It's a coronal cut. Coronal means I take serial cuts, every 5 mm cut from the nose to the exit backwards. Every 5 mm I take a cut. This is an example of submucous infiltration. If we see in the nasopharynx here, this is the tongue, and this is the palate, and this is the cavity of the nasopharynx. If we see here, there is just very mild elevation in this area. However, the mucosa overlying the tumor is very intact. If I inserted an endoscope and pass through the nasopharynx, I will find nothing. I will find any masses. However, there is a huge tumor erosion eroding the skull base and extending intracranially without any evident mass in the nasopharynx. This is a pure example of submucous extension. MRI, as I said before, soft tissue involvement can be better explained and can be better evaluated under CT, under MRI examination. Also, we do chest X-ray and bone scan to demonstrate if there is extension outside the tumor if there is distant metastasis or not. Treatment of nasopharyngeal carcinoma, the main line of treatment, the only line of treatment is definitive radiotherapy, external beam radiotherapy. Why we don't use surgery in treatment of nasopharyngeal carcinoma? Because the nasopharynx is not an organ, it is a potential space. If I remove the skull base, I can't remove the skull base above, I can't remove the superior constrictor muscle, I can't remove the nose anterior, I can't remove the soft palate. So the primary treatment of nasopharyngeal carcinoma, if I asked you what is the treatment of nasopharyngeal carcinoma in one word, it is radiotherapy. This is a post-irradiation picture 6 months after treatment. This is a very promising picture. I am entering from the right nasal cavity because this is the nasal septum on my right side, so I am on the right nasal cavity, and this is the end of the inferior turbinate, and this is the overlying mucosa of the nasopharynx. We should see how the mucosa becomes smooth and without no vascularity, without no masses, so it is a promising picture. This is a CT pre-operative, pre-radiotherapy, and 4 months post-radiotherapy. What we see here, this is the nasal septum, this is the maxillary sinus cavity, this is the maxillary sinus cavity, this is the inferior turbinate, and this is the inferior turbinate. Okay, we see here soft tissue mass filling the nasopharyngeal cavity. It's supposed to find black color, black لون، يعني لون اسود في منطقة النيزوفارينكس علشان اعرف بما ان ده فيه اير، لكن في الصورة انا شايف soft tissue mass filling the nasopharyngeal cavity and extending up to reaching the nasal cavity. In the 4 months post-operative radiotherapy picture, this is the nasal septum. This is the same patient, and we can see there is some shrinkage of the tumor. I can see air in the nasopharynx, and the tumor shrinked markedly with radiotherapy. So, response to radiotherapy is promising. Surgical treatment is restricted to mainly diagnostic, means I take a biopsy from the tumor to confirm that it is a tumor. Number 2, local treatment for regional lymph nodes. If there is nasopharyngeal carcinoma, I can give radiotherapy to the primary tumor, to the nasopharynx and cervical lymph nodes, or do radical neck dissection for lymph nodes. Also, ostichian tube dysfunction, unilateral secretocyte media have to be treated surgically by ventilation tubes. And the type of ventilation tube in this case is T-tube. I remember we have 2 types of ventilation tubes. Grommet tube or temporary tube. I use this type of tube if there is temporary cause of ostichian tube obstruction, like adenoid. If I remove the adenoid, secretocyte media will improve with ventilation tubes. But if there is permanent damage to the ostichian tube, permanent invasion of the muscles by tumor, or permanent hypoplastic muscles, as in case of cleft palate, so this patient will in need of T-tube. The therapy, it may be adjuvant. It means the additional treatment in association with radiotherapy. I can give chemotherapy or immunotherapy. However, all these lines are primitive and additional or adjuvant to radiotherapy, and they cannot replace radiotherapy. Thank you. يا رب المحاضرة تكون بالنسبة لكم واضحة. لو في أي أسئلة بالنسبة للموضوع ده أو أي موضوع تاني في أنف وأذن، هديكم رقمي علشان تبعتوا لي فويس مسج على الواتساب، عشان لو في أي حاجة مش واضحة ممكن أوضحها لكم تاني، أو في أي أسئلة. 011 432 3706. شكرا جزيلا. السلام عليكم.